Hello, I'm Ruth Newby and this is Pathophysiology for nursing students. This presentation will focus on pancreatitis. It will discuss pancreatitis in the context of the nursing evaluation and care of the patient with the condition, the symptoms and related medical conditions, the pathophysiology procedures and nursing care of the patient. I'll very briefly review the anatomy of the pancreas, but I will need you to undertake your own revision. The pancreas is located in the epigastric region of the upper abdomen, posterior to the stomach. It's considered to be part of both the digestive and endocrine systems because it has both exocrine and endocrine function. The exocrine function of the pancreas involves the production and release of several digestive enzymes, amylase for carbohydrate digestion, lipase for the digestion of lipids, and trypsinogen and chymotrypsinogen, which form trypsin for protein digestion. It also releases bicarbonate, which alkalizes the stomach contents as they enter the duodenum. As for its endocrine activity, the pancreas is involved in the production and release of several hormones, which are related to blood glucose homeostasis. So insulin from the beta cells and glucagon from the alpha cells, and also somatostatin. These secretions travel along the pancreatic duct system and they enter the intestines through the papilla. Pancreatitis is inflammation of the pancreas, either acute or chronic. It's one of the least common diseases of the digestive system, and episodes of pancreatitis can be either sudden and severe, that's acute, or ongoing, which is chronic pancreatitis. They have different but overlapping symptomatology and often etiology as well. They often both cause upper abdominal pain, nausea and vomiting, which is worse with eating. Pain commonly radiates into the back. So pancreatitis can present as a relatively mild condition or as a medical emergency associated with a risk for life-threatening complications. The principal cause of pain and inflammation in pancreatitis is inflammation and also hemorrhaging due to the destruction by the individual's own digestive enzymes, which we call autodigestion. Acute pancreatitis is often caused by gallstones, and chronic pancreatitis is more often related to the ingestion of alcohol over the long term. You'll notice on the diagram on slide 5 that while the pancreatic duct carries exocrine secretions into the duodenum, it is shared for part of its length with the hepatic duct, which carries bile from the liver and the gallbladder. So the causes of both acute and chronic pancreatitis often relate to the pathology of the liver and the gallbladder, but we will deal with them separately. They range from mild and self-limiting, so discussing acute pancreatitis first, from mild and self-limiting, which will resolve within a period of days, to severe and rapidly fatal acute pancreatitis. Severe acute pancreatitis can be a result of complete enzymatic digestion of the pancreas. So enzymes damage local blood vessels, and bleeding and thrombosis can occur. In this condition, local complications due to tissue digestion and inflammation occur. So the patient is acutely ill in severe pain, at risk for hypovolemic shock, and also fluid and electrolyte imbalance and sepsis. Some of the causes of acute pancreatitis: damage by alcohol to the liver and the pancreas, firstly, and also biliary tract disease, including gallstones, can cause complete or partial occlusion of the hepatopancreatic duct. Postoperative conditions, ERCP in particular, we'll discuss that later. Traumatic damage, some drugs, most commonly corticosteroids like prednisolone, but also some HIV drugs, and also infections such as mumps and cytomegalovirus. Hypercalcemia and tumours are also involved. The most common cause, as we mentioned earlier, of severe acute pancreatitis is gallstones blocking the pancreatic duct. And in fact, this can also occur even if the gallbladder has previously been removed. And as we said, this can result in the release and activation of the proenzymes and severe pain. The symptoms of acute pancreatitis are similar to and may be confused with symptoms of other emergencies such as heart attack, biliary colic, or perforation of a gastric or duodenal ulcer. Acute pancreatitis generally causes severe pain, and the sufferer will need emergency treatment in hospital. Clinically, patients with acute pancreatitis present as acutely ill with sudden onset, severe abdominal pain, abdominal guarding, mid-epigastric pain radiating to the back, nausea and vomiting, which is worse on eating, increased heart rate, bloating, decreased blood pressure. They may have Cullen's sign, which is a bluish discoloration around the belly button, or Gray Turner's sign, which is discoloration on the flanks of the abdomen due to retroperitoneal bleeding. Absence from drinking usually resolves acute pancreatitis if it's triggered by acute alcohol consumption. Individuals may also have sweating, fever, jaundice, and mental confusion. During an attack, patients may assume a characteristic position that's inclined to relieve their pain. That is lying on the left side, flexing the spine and drawing the knees up towards the chest. They also experience respiratory distress, hypoxia, tachypnea, hypotension, and dark-coloured urine, and sometimes, more often in chronic pancreatitis, but sometimes steatorrhea or oily or fatty stools. So for diagnosis of acute pancreatitis, your patient will receive a physical examination and some general testing such as medical imaging, x-rays, blood tests, abdominal ultrasound. There is a special MRI which we can use also that your patient will undergo, and some blood and stool tests, blood tests to look for elevated levels of pancreatic enzymes, and stool tests to measure levels of fat, suggesting the digestive system may not be adequately absorbing nutrients. Magnetic resonance imaging looks for abnormalities in the gallbladder, the pancreas, and the ducts. A special form of MRI called MRCP can be used, and also an ERCP, an endoscopic retrograde cholangiopancreatography is used in diagnosis. So many patients will be under the care of a gastroenterologist. The goals of care for nursing staff are firstly the relief of pain, the prevention or alleviation of shock, so support for the respiratory system, which is often compromised, particularly due to the severity of the pain. The decrease of pancreatic secretions is very important, so the use of a nasogastric tube in order to rest the gut from stimulation by food, and also the maintenance of fluid and electrolyte balance, and ensuring that your patient has adequate nutrition and hydration. Treatment of acute pancreatitis begins with the treatment of underlying causes, particularly in the case of gallstones, so procedures to remove bile duct obstructions are important. Discontinuing medications which may be causative, and the cessation of alcohol ingestion. Initial treatments in hospital include fasting. So the patient will often be asked to stop eating for a few days to give their pancreas a chance to recover from the damage. And once that is controlled, they may begin to be offered clear fluids and bland foods, ultimately going back to their normal diet. So complications of acute pancreatitis, as we mentioned, it can be a very serious illness. The main systemic complications are pulmonary and cardiovascular, the potential for electrolyte imbalance, and particularly for hypocalcemia, is very important. A pseudocyst is an important complication of acute pancreatitis that you need to know about as nurses. So the cavity, a cavity surrounding the outside of the pancreas becomes filled with the necrotic breakdown products of pancreatic autodigestion and their liquid secretions. This causes immense abdominal pain. The patient will have a palpable epigastric mass. They will be likely to be vomiting, have severe nausea and anorexia, and blood tests will confirm elevated serum amylase. A pancreatic abscess is another severe complication of acute pancreatitis. It's a large fluid-containing cavity within the pancreas resulting from extensive necrosis. It causes upper abdominal pain, high fever, and typically a leukocytosis. The potential for fatal outcomes in pancreatitis is higher if pancreatic necrosis has occurred. So there are actually predictive algorithms and scoring systems based on things like age, lab results, and renal failure, though that's not necessarily relevant to your nursing practice. Shock is a particular concern, so septic shock, hypovolemic shock, or distributive shock. So your observations of the patient are particularly important in this case. Patients can also have elevated blood glucose levels because of their impaired ability to produce insulin, which is damaged by the process of the pancreatitis and the impairment of pancreatic function. There's the potential for fatal outcomes in pancreatitis. So 2 to 9% of patients with severe acute pancreatitis may have a fatal outcome. And as I mentioned, shock is a particular concern. This is due to the release of inflammatory mediators and vasodilation, elevated blood glucose, so hypoinsulinemia, and third spacing, including as a result of pancreatic edema. Let's go on now to chronic pancreatitis. Inflammatory change, which is very long-standing and progressive over many years, is an important consideration in chronic pancreatitis. So what we see is chronic irreversible inflammation and destruction of pancreatic tissue with fibrosis and sometimes calcification, which can be imaged and found in MRI and CT scans. We find that the pancreas has a progressive loss of function. Chronic pancreatitis often begins between the ages of 30 and 40 years. It's rare in children. So these patients may have a very long history of medical intervention. Inflammatory change, which is long-standing and progressive over a number of years. And there may be many associated pathophysiologies which have been previously discussed in this presentation. The presentation is highly variable. There's commonly steady weight loss as a result of poor nutrition, long-standing diarrhea, the accompanying nausea and vomiting and anorexia, abdominal pain, which is highly variable, for which patients have pain relief, which in itself can cause long-standing complications. Patients may have intermittent attacks of severe pain, particularly after meals, but sometimes independently of meals. So your patient's history is quite variable, potentially. Pain after meals is not necessarily fleeting or transient. It tends to last for several hours. Patients are often symptomatic for years before diagnosis of a chronic pancreatitis is established. The average time from the onset of symptoms until a diagnosis is achieved for acute pancreatitis is often up to 62 months. And if alcoholism is not present, it may be longer. So let's go on now to a diagnostic approach. Tests of pancreatic structure and function are very important, and imaging for pancreatic calcifications. The ERCP, the endoscopic retrograde cholangiopancreatography, is important and a commonly used test for which your patient will be subjected. Treatment is usually directed towards underlying cause of the pancreatitis to relieve the patient's pain and malabsorption. Management of acute pancreatitis. Pancreatic enzyme supplementation may be helpful in reducing pain. Also celiac blockade, celiac ganglion blockade, and there are also surgical options, improving the pancreatic ductal drainage and resection of the pancreas. Some of the surgical procedures which patients undergo are the Roux-en-Y cytosite pancreaticojejunostomy and the Whipple procedure. In the long term, patient education to modify behaviours that may exacerbate the natural history of the disease are really important. These enable the pancreas to heal itself. So, determining the cause of abdominal pain and alleviating it, detecting pancreatic